All right, guys. So we're going to go over chapter 4, communication and documentation. For those of you doing the hybrid portion, we can go over this in class some more because we're going to practice it from here on out. But documentation, we're going to really work on proper documentation on patient care reports. Some of this is best in person, but I'm going to try to explain it the best I can on here. So therapeutical communication, principle of communicating with patients in a manner that achieves a positive relationship. And I've talked about it before. We want to earn their trust in a matter of seconds. When we first arrive, we need to make sure that they trust us, they know who we are. So we're going to talk about interview techniques, adjusting communication strategies for different ages or development, patient with special needs, and difficult cultures. Excuse me. Um, Verbal diffusing strategies and family uh, presence and issues. Sorry, presence issues. Communication needs, calling for resources, transfer of care of the patient, interacting with a team structure, EMS communication system, communication with other healthcare professionals, and team communication with dynamics. Documentation, recording patient findings, principles of medical documentation, and report writing is what we're really going to really hit on. A lot of this is my favorite word, common sense. Uh, so medical terminology used foundation to anatomical, and medical terms and abbreviations in writing and oral communication with colleagues and other healthcare professionals. Um, Chapter 5, I believe, is medical terminology. Uh, Brooke, the other instructor, she's going to do that chapter just because it's not my strong point by any means. And so we're going to use medical terminology. She's going to be assigning homework throughout this class that has something to do with medical terminology, mainly because in order to take these tests and these quizzes and to understand the way things are worded or questioned, you need to have an idea of correct medical terminology. Once we hit the real world and you're running in a truck, yes, you need to know it, but we speak in plain language, especially to patients and stuff. And we're going to talk about that more in communication. So, communication is the transmission of information to another person, whether it's verbal or nonverbal through body language. Verbal communication skills are important. It enables you to gather critical information, coordinate with other responders, and interact with other healthcare professionals. And then documentation, patients, um, pertinent medical record. It demonstrates appropriate care was delivered and helps others in patient's future care. Complete patient record guarantees proper transfer of responsibility, comply with requirements in health department and law enforcement agencies, fulfill your organization's administrative needs. So this goes back to like chapter 1 and 2 when we were talking about nationally, they take our patient reports and they look at them and they decide, hey, what works, what doesn't. Well, this is a little bit lower level. The hospital receives our report. They can see what we've done. Our administration sees our reports. And it just keeps everybody on the same level to make sure we're giving good quality care across the board consistently. Computer, radio, and telephone communications. Link the EMT to EMS, fire department, and law enforcement. You must know what your system can and cannot do, how to use the system effectively and efficiently. Uses of various communication techniques and strategies, uh, both verbal and nonverbal, encourages patients to express how they feel, achieves a positive relationship with each patient. So the Shannon Weaver communication model, sender takes it through, encodes it into a message, sends the message to the receiver, receiver decodes the message, sends feedback to the sender. There's a whole lot there. So here's kind of a diagram that explains it, um, and breaks down the process. I don't want to say you don't need to know this, but you talk to someone, you send it as a message, it gets decoded, it goes to the person hears it, they respond, it comes back to you. Um, so when we're talking about communication, some of the things we need to consider is age, and appropriate communication with that age, making good eye contact. Your body language and facial expressions say a ton. Clothing and which sex you are, male or female, plays a huge role. Culture or posture, education, voice tempo, environment, and volume. So you all know I use myself as an example. I am mostly deaf in my right ear. So when I'm in a truck and there's sirens going and the little old lady or old man's trying to talk to me, a lot of times I have to get right down and listen to them. But that doesn't mean I need to yell back at them. They might have perfect hearing. So you need to take those kind of things into consideration. Let's see, age, culture, and personal experience. So um, it influences how a person communicates. Body language and eye contact are greatly affected by culture. In some cultures, expressing emotion is a weakness. In other cultures, it is impolite to look away while speaking. Once again, back to chapters 1 and 2, we don't judge. We don't, well, they won't look at me, so I don't trust them. We just, we read the room, we read the patient. We have got to be very adaptive when it comes to communication with different patients of age, culture, race. The whole nine yards plays a role in here. So tone, pace, and volume of language, reflect mood of the person and perceive importance of the message. We once again read your patient. Um, if you're calm, they're going to be a little bit calmer. If you're knowledgeable, they're going to trust you more. So, never consider your own culture values more important than those of others. Cultural imposition forces your values onto you. Can't force your beliefs on other people. Um, Nonverbal communication, so body language provides more information than words alone. Even without exchanging any words, you should be able to tell the mood of your patient. You can watch their body language, look at the color of their skin, watch their movement of their hands and arms. Are they agitated? Are they scared? Are they shaking? Read your patient. Facial expression, body language, and eye contact are powerful communication tools. Help people understand messages being sent. Goes right back to what we just talked about. When treating a potentially hostile patient, be aware of your own body language. Don't come off as threatening. Don't come off as, by golly, I'm in charge. That's how it's going to be. Stay calm and try to diffuse that situation. Assess the safety of the scene before we do anything. Do not assume an aggressive position. Make good eye contact, but do not stare. Speak calmly, confidently, and slowly. Never threaten the patient, either verbally or physically. This goes back to when I said never get yourself backed into a room. Always have an exit. Um, if you just don't feel good about it, call PD and have law enforcement officers there to assist you, even if they just stage outside. Um, it's good to have that backup if you don't feel safe. Yes, we're there to help people, but we can't help them if something happens to us. Physical factors, so literal noise, um, or sounds in the environment, lightning, um, distance, or physical obstacles may affect your communication. Cultural norms often dictate the amount of space or proximity between people when communicating. Gestures, body movement, and attitude towards the patient are critically important. So once again, the noises, I have no problem telling my patients, I'm sorry, I can't hear out of my right ear. I'll turn my head, use my left side, get a little bit closer. Sometimes they will talk louder. And if same thing, if they tell me, hey, I have bad hearing, then I can adjust my approach. Um, knowing the cultural norms is pretty important. And back to the body language and attitude, guys, we're there to help them. We should not have an aggressive uh, body movements or gestures, even when we're 3 in the morning when we go to a toe pain that's been hurting for 4 days. Is it aggravating sometimes? Definitely, but that's what we do. That's what we signed up for. And that's what I tell myself a lot whenever I get upset over something. That's what I signed up for. I know this is going to happen. Asking questions, so verbal communication, asking questions is a fundamental aspect of pre-hospital care. Open-end questions require some level of detail. Um, use whenever possible. Example, what seems to be bothering you? So an open-ended question is something where you're going to get a story. You're leaving it open for them to tell you. A closed-end question is a yes or no. So what's been bothering you? Why'd you call EMS today? That's an open-ended question. Does your stomach hurt? That's a yes or no. That's a closed end. Um, Me personally, when I'm getting information and I'm trying to find out a chief complaint, I like to tell them, tell me what you're feeling in your words. Because what I got going through my head might be completely different when what that patient's feeling or telling me. So I have to be open-minded and I have to allow them to tell me exactly how they feel. And then it's my job to put that puzzle together and figure out what's going on. Closed-ended questions can be answered in very short responses. Response is sometimes a single word. Are you having trouble breathing? That's a closed end. It's right there. Are you having trouble breathing? Don't need anything else. I didn't ask about your toe. I didn't ask about your heart. Are you having trouble breathing? Yes. So closed end question. Communication tools, facilitation, pause, reflect, empathy, clarification, confrontation, explanation, summary, interpretation. Let's see. Interviewing technique. When interviewing a patient, consider using touch to show caring and compassion. Use consciousness and sparingly. Avoid touching the torso, chest, or head. Um, so what she's doing here is perfectly fine if the patient's fine with it. I have never had a patient get upset with me when I pat their shoulder or I lay my hand on their hand. This is comforting. This lets them know that you care about them. It's just a good technique. Interviewing techniques to avoid providing false assurance or reassurance, giving unsolicited advice, asking leading or biased questions, talking too much, interrupting, using why questions, use authoritative language or using authoritative language, and speaking in professional jargon. So that one right there is kind of important. We don't use medical terminology with patients. We don't. We talk to them clearly so they understand it. Um, we don't want to scare them, but we also don't lie to them. We don't give them, oh, you're going to be fine when we know better. Um, you can say, I'm going to do everything I can to help you, or we're doing everything we can. Best thing you can do right now, stay calm. Those type of things are okay. Uh, Presence of family, friends, and bystanders. So that you're going to deal with this a lot. Friends and families may be valuable during a patient interview process, but you need that patient to answer the questions if at all possible. Um, Allow the patient to answer, even if well-meaning family members attempt to answer the individual. Sometimes you just have to go, I need them to answer. I'm sorry. Um, do not be afraid to ask others to step aside for a moment, which sometimes you just have to do. If that patient is within their right mind and answering questions appropriately, let them answer the medical questions. They know better than anyone else what's going on with them. Um, you're gonna get those old men who, okay, what meds do you take and for what? Ask my wife. She has a list. That's fine. That's okay. How are you feeling? Why did you call us today? Can you explain your feelings to me in your words? They need to answer those. Golden rule, make and keep eye contact at all times. Provide your name and use the patient's proper name. Tell the patient the truth. Use language and patient or use language the patient can understand. Be careful what you say about the patient to others and be aware of your body language. Eye contact's big. It shows that you are confident, it shows trust, it shows respect. Providing your name and use the patient's proper name. Ask them, what would you like to go by? How would you like me to address you? Um, tell the patient the truth about what's going on. I am really, really big on we verbalize everything we do in class and out of class. Um, no matter what it is, if you're gonna fix the patient's blanket, tell them, hey, I'm gonna adjust this blanket a little bit. Hey, I'm gonna put a capno on you and give you some oxygen. I explain everything I do to my patients. Um, use language the patient understands. Once again, education, educate, educate. So if that patient said, well, what's a capno? It's a fancy nasal cannula that I can watch you breathe on my monitor. That's pretty cut and dry, easy to understand. Oh, okay. Um, be careful what you say about the patient to others. They are alert. Don't be talking all this negative stuff to the family member or to your partner while that patient can hear you. And once again, body language. Speak slowly, clearly, and distinctly. Make sure they understand. Ask them, do you understand everything I've explained to you so far? If the patient is hard of hearing, face the patient so he or she can read your lips. Allow the patient time to answer or respond. Act and speak in a calm, confident manner. Once again, if you guys put the work in to learn the material, you can be confident. You might not feel like it, but if you put the work in, I promise you, you will know your stuff. Um, emotional intelligence. So, ability to understand and manage your emotions and properly respond to others' emotions. Helps with diffusing conflict, building the rapport, communicating effectively, and managing difficult situations. Attributes to emotional intelligence is self-awareness, self regulation, motivation, empathy, and social skills. So most people have decent social skills in this class. By the end of it, we are going to work together enough with each other that we will work on social skills that will benefit you out there in the real world. Improve emotional intelligence, or improving emotional intelligence assesses how you react to a stressful situation, practice mindfulness, focus attention on the present moment, take responsibility for your actions, and consider how your actions will affect others. So, I can't teach you how to respond in a stressful situation. I can put you in scenarios that might get your heart rate up a little bit, but um, some people thrive. The worse the call, the more they are in touch with themselves and their knowledge. Some people go into a panic and forget everything. So we will practice this in class, practice mindfulness. So focus attention on the present moment, their emergency, not yours. I tell myself that every single call. This is my job. not my emergency. Take responsibility for your actions. If you make a mistake, own up to it. Let's fix it. I told you in like chapter one, it's never a failure if you learn from it. So when you make those mistakes, fix them, study them, figure out why it was a mistake, and you won't do it again. It's not a failure if you learn something. Take responsibility when you screw up and consider how your actions will affect others. Put yourself in someone else's shoes. Um, just a sign of emotional intelligence. If I say this, how would that make me feel? If I do this to so and so, how would that make me feel? Um, it's just good practice. Behavioral change stairway model. So developed by the FBI to manage hostage situations, adapted for crisis management, employ active listening, display empathy, build a rapport, sorry, um, exert influence, and initiate behavior change. Communicating with older patients. Identify yourself. Present yourself as competent, confident, and caring. Do not assume an older patient is senile or confused. We don't just walk in there and treat them like that they're deaf and they don't know anything. We respect our elders every call. Um, we show that compassion. Um, introduce yourself, what you do, how can I help you today? What seems to be the problem? Calm, almost a soothing voice. We almost change who we are um, to calm that patient or help that patient feel like we're the right people for the job. You may encounter hostility, irritability, and some confusion. Do not assume this is normal behavior. Approach the older patient slowly and calmly. Allow plenty of time for a patient to respond to your questions. Watch for signs of confusion, anxiety, impaired hearing, or vision. The patient should feel comfortable or confident that you are in charge and that everything possible is being done for him or her. Be patient. If you are verbalizing everything you do and you explain why you're doing it, they will be more calm. They will have that confidence that you are the person for the job. Your older patients often do not feel much pain, may not be fully aware of the important changes in their body systems. You must be especially vigilant to objective changes. As we get into assessments, we'll get into what to look for, how important it is to actually be very vigilant. When possible, give patients time to pack a few personal items before leaving, or you or your partner go do it. Hey, where is that? And we'll get it for you. Um, locate hearing aids, glasses, dentures, cell phones, chargers. Uh, older patients often worry about the safety of their home, their valuable items and pets. Ask if they want you to lock up for them. Ask if you can call a family member or a neighbor to help take care of the pet because they will stress more over that pet than they will what's wrong with them. So that is part of taking care of that patient is letting them know everything's been taken care of, everything will be fine. Fear is most uh, obvious and severe in children. Children may be frightened by your uniform, the ambulance, a crowd of people gathering around them. So sorry, we've moved on to children now. People see us, even with this little star life, they see us as an authority figure for some reason. Uh, so kids and some adults um, are fearful of us. They think that we're tied in with the law enforcement or we're gonna stab them with needles. So we have to approach this very delicately and professionally. The ambulance can be scary to kids. because all they know is people get hurt and they get put in an ambulance. And then crowds. We do our best to control this, but when a kid's down or hurt, people do gather around. They do want to help. So we need to kind of know what's coming if that happens. Let a child keep their favorite toy, doll, security blanket. If possible, you have family member or friend nearby. If practical, let the parent or guardian hold the child during evaluation and treatment. So this is really important. Um, and we're going to talk about this in other chapters, but what's going to keep that child the calmest is what we want to do. I know our ambulances, we keep stuffed toys on them. We keep little stuffed animals. Um, I have actually transported children 3 hours away, and we made about 80 glove balloon animals in the back of the truck that night. But that's what kept that child calm. So it's those little things, be creative. I keep Disney Plus on my phone and on my tablet. I've done that during long transports with children. Put on Bluey, put on their favorite cartoon. It's little things like that that will help you with these kids. Be honest. Children easily see through lies and deception. Tell the children ahead of time if something will hurt. Respect the child's modesty. Um, Definitely, we don't want to scar this child for life. So we need to be very open. We need to talk to the child, but make sure that the caregivers are also paying attention and understand. Um, if say I do need to start an IV or give a shot or something, um, we need to word it to where it's not as scary. So just use some common sense there. Speak in a professional, friendly way. Maintain eye contact. Position yourself at that child's level. Um, let them use your stethoscope. Let them put the blood pressure cuff on mom or dad or whoever. Uh, Explain what all the fun toys in the ambulance are. Whatever it takes to get them to trust us and realize we're not scary bad people. So communicating with the hearing impaired patient, most have normal intelligence and are not embarrassed by their disability. Position yourself so that the patient can see your lips. Hearing aids, be careful that they are not lost during an accident. They may be forgotten if the patient is confused. Ask family about using hearing aids. Um, s- Steps to take to effectively communicate with patients who are hard of hearing. So have paper and pen available. Sometimes writing is a lot easier. If the patient can read lips, face the patient and speak slowly and distinctly. Never shout. Don't just get there and yell at them. A lot of times it's a muffle is all they hear, and it looks like anger when you're yelling or shouting, and you're not going to get that rapport. You're not going to get that respect and trust. Listen carefully, ask short questions, and give short answers. Learn some simple sign language. If you want to, that is awesome. Um, I haven't. Shame on me. I probably should, but ask the patient if he or she can see it all visually. Oh, we're on visually impaired. Sorry. Visually impaired patients are not necessarily completely blind. Expect the patient to have normal intelligence. Explain everything you are doing as you're doing it. This should be every single patient. You're going to hear this 10,000 times. Verbalize every move you make to every single patient. Um, yeah, just because they're blind doesn't mean they're deaf or they're not smart. Just like if they're deaf, it doesn't mean that they're not intelligent. So we don't treat these people any different. It's just the way we communicate is different. Stay in physical contact with the patient as you begin your care. If the patient can walk to the ambulance, place him or her. Oh, sorry. Oh. Hand on your arm, and you can guide them. Transport uh, mobility aids such as a cane with the patient to the hospital. So canes and walkers, if we can take them, we need to. Wheelchairs are a little harder to take in an ambulance. Um, but if we're able to transport that, let's do that. Guide dogs, easily identified by special harnesses. If possible, transport dog with patient. It alleviates stress of both the patient and the dog. Otherwise, arrange for care of the dog. Um, let family bring the dog. I'm going to throw one other thing out. You also need to be careful because some of these are very protective of their owner. I'm not saying that these dogs are mean or bad, but just that's one of them scene safety. Make sure you can even ask the patient, is your dog going to get mad when I approach you? Just keep that in mind. Non-English speaking patients. So you must find a way to obtain a medical history, find out if the patient speaks some English, use short, simple sentences, point to parts of the body, have a family member or friend interpret, uh, consider learning some common phrases of other languages that you might use in your area. Pocket cards that show pronunciations and terms are available. Use a smartphone app or a website to help translate. Remember to request a translator at the hospital. Mission critical communication. So communications or disruption, where disruption will result in failure of a task at hand. Share mental model. A mental model is a picture an individual has in their head of what's going on. All team members must share a mental model. So we just communicate with each other, make sure we know what we're looking at. Um, Questions to ask: what is the focus priority of the patient? What is the history of prior care? What is the patient's current state? And what is the patient's immediate needs? Effective communication is essential to efficient, effective, and appropriate patient care. Um, Transfer pertinent patient information and responsibility of that patient care. So when we do patient handover, what we're doing is we're going to say what we got called for, what we find, what we do, how they react up to this point. So I got called for low blood sugar. I arrived on scene, found the patient, altered mental status, blood sugar of 42. I administered, or I started an IV. I administered uh, D10. Patient's blood sugar came up to 71. We transported patients alert and oriented and able to answer questions appropriately. No changes since then. Um, that was a real quick report, handover report. Uh, Give a handover report, initiate eye contact, manage the environment, minimize noise, interruptions, and distractions, and ensure ABCs, which we haven't even got to yet. ABCs is airway, breathing, circulation. Provide a structured report. Um, C-bar, situation, background assessment, recap, treatment. CBAT or SBAT, um, situation, background assessment, and treatment. So, situation, what caused it, the background, what I found, what I did. Provide documentation. Should include patient priority condition, prior care, current state, and immediate needs. If you are receiving the handover report, so you show up, an EMR has been on scene, you show up as an EMT, and they're giving you a report, maintain that eye contact, manage the environment, ensure understanding, summarize it, gather supplemental patient documentation. Written communication documentation, patient care report, or PCR, also known as pre-hospital care report. Um, it is a legal document, records all care from dispatch to hospital arrival. There are two types of PCRs, written and electronic. Most everything's electronic now. The PCR serves six functions: community of care, the compliance and legal documentation, administrative information, reimbursement, education, data collection, and continuous quality improvement and research. I know that sounds really like a whole lot. It's really not. Information collected in the PCR. So the things that an electronic patient care report is going to have everything from your run number, which is the ID number more or less of that run, scene location, address, times, who was on the call. And then we go into like chief complaint. So why was we called? What was wrong with the patient? What happened to cause the problem? Was the patient alert? Were they unconscious? All the vital signs we take. So if we take 27 vital signs, they're going to be in that report. The ongoing assessment. So we do an assessment, which you guys will learn, and then we put that in there and we put ongoing assessment so we can actually watch if that patient's trending down and treatment's not working, or if that patient trends up because our treatments are actually improving the patient. So the vitals and the assessment will show a trending pattern, patient demographics, and then transport information. So what really happened during transport? What did we find? What did we do? How'd they react? And we'll talk about different types of documentation here in a minute. Administrative information gathering from the PCR include the incident was reported, EMS unit was notified, the EMS unit arrived, the EMS unit left, the EMS unit arrived at the facility, patient care was transferred, and the unit's back in service. So we had to recognize an issue. Someone called 911, EMS was notified. We rolled out of the bay and arrived on scene. What time did we load the patient and leave the scene? What time did we arrive at the hospital? And what time did the nurse or doctor take control of that patient? And then what time did we get restocked and go back in service? So traditional writing forms with check boxes, narrative section, and computerized version. So, I mean, this is different than the one I use, but they're all pretty much the same. What was the call? Where was it? Um, was it a 911 call? Probably. Did we respond lights and sirens? Did we respond no lights and sirens? What was the main cause for the call? What's the patient's first, last name, address, phone number, all of that. Um, and then, so there's all kinds of these little check boxes. We get to a point called the narrative. So the narrative is where we're actually going to start typing things out. This D chart, we use D chart E. So literally on my reports, I will have D and then a slash dispatch to residents, blah, 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 blah. I'll go down C slash chief complaint. Patient's chief complaint is shortness of breath. Go down H slash history. Uh, Patient has a history of CHF and um, had COVID. A assessment. Patient was located sitting in the living room in his recliner, leaned forward in the tripod position. Patient noted to be pale, cool, and clammy, showing work of breathing. Rails noted when lungs were auscultated. You go into detail. How was the patient found? What did you do? Treatment. This is what treatments we actually did. So patient was placed on the cot and semi-Fowler nebulizer breathing treatment was applied to patient. Probably not with CHF, but um, you would say what treatments you had performed for that patient. And then transport, patient placed in a waiting unit, patient transported to whatever hospital. During transport, continuous vitals and assessments were completed with no change in patient condition, or patient shows improvement after breathing treatment. Oxygen saturations noted to be 89 and now 98. Patient states relief in the chest and he can breathe better now. Verbal report called into receiving facility with an ETA of 15 minutes upon arrival. Patient was taken to ER Bay 01, where verbal report was given once more. Patient moved on to hospital bed using a team lift method. EMS gained needed signatures and was cleared of scene, returned to service area and placed back in service. That was pretty much it. There, so your narrative, if you break it down letter by letter by letter by letter, um, it's not hard at all. Uh, you get the information you need. You just need to make sure that the information in your narrative is the same as the information in your flow chart and in your assessment chart. And I know that sounds like a lot, but we will practice this in class, I promise. We use DChartE. There's also one called SOAP, Subjective, Objective, Assessment, and Plan. I have not personally used that one. All narrative sections should contain the time of the event, the assessment findings, the emergency medical care provided, changes in the patient after treatment, observation at the scene, final patient disposition, refusals of care, if there was one, and staff personnel who continued care. That would be the signatures that we gain at the facility, wherever we go. Okay, health information exchanges. So improve sharing of data between EMS and other healthcare providers allows access to relative health data. Unnecessary uh, duplications of efforts in data entry, access to patient outcome related to hospital care, and contribution and access to electronic health information on a regular basis. The HIAs uh, follow the SAFR framework. So search hospital and other records, alert, notify hospitals of incoming patient, file, incorporate data directly into the patient's health record, and then reconcile outcomes and other data provided by EMS agencies for billing and quality assurance. Reporting errors. If you leave something out or record it incorrectly, do not try to cover it up. That's called falsification. Results in poor patient care, may result in suspension or legal action. So if you screw something up, you simply put one line through it and you initial it. And this is on written reports. If you do an error on an electrical report, we can still go back and admin it. You just need to let your supervisor know. If you discover an error as you're writing your report, draw a single horizontal line through it and initial it. Okay. If an error is discovered after you submit a report, follow the same process. Or you just let your supervisor know because everything's electronic now. Sometimes they have to go back and actually unlock it because once you lock it, you can't get back into it. Sometimes they can be unlocked and you don't take anything out. You go into that narrative section at the bottom and you will add to it. The time, the date, correction being made due to, and you go that route. So a common source of loss, documenting refusal of care, a common source of lawsuit through documentation is critical. Thorough documentation is critical. Document any assessment findings in emergency medical care given. Have the patient sign a refusal of care form. Have family members, police officer, or bystanders also sign and witness. Complete the PCR. That goes back to that story I told you before about the brain bleed. You have got to get a signature on every refusal. You've explained to them what could happen if they don't go to the hospital. They still refuse. Okay, I need a signature. You want a witness to that signature, if at all possible. Just stating that yes, they seen it, they heard that they didn't want to go to the hospital. That way, if that person in 2 or 3 hours, 1 or 2 days drops dead, you're covered. he told me no. His cousin who signed this paper heard him say no. This is on me. It's just a protective thing. Always get a signature on those refusals, and then uh, go ahead and do that patient care report as soon as possible. Special reporting situations. So depending on local requirements. So gunshots, dog bites, some infectious diseases, suspected physical or sexual abuse, multiple casualty incidences. These things need to be reported. And you'll probably have a separate incident report paperwork in your agency that you have to do for those. Communication system and equipment. So radios and telephone communication links. You and your team with members of EMS, fire, and law enforcement communities help the entire team work together more efficiently, provide an important layer of safety and protection. Base station radios contains a transmitter and a receiver in a fixed place. So just remember this, base station radios, it's a two-way radio that's at the station. It doesn't move. It's like your scanner at home. A dedicated line, also known as a hotline, is used for specific point-to-point contact. So the base radio is at the base. It doesn't leave the base. Mobile or portable radios. Mobile radio is installed in a vehicle. It's mobile. Okay. Used to communicate with dispatch and medical control. Ambulances often have more than one. Sometimes they're also one in the back. Portable radios are handheld devices. They're portable. They walk around with us. Essential at the scene of a MCI. Helpful when away from the ambulance to communicate with dispatch, other units, or medical control. A repeater is a special base radio. Receives messages and signals on one frequency, automatically transmits them to a second frequency, allows two mobile or portable units that cannot reach each other directly to communicate using its greater power antenna. That's really confusing. I get it. The repeater, though, just remember, it takes it in, puts it in a different frequency, and sends it back out. It's repeating it after it changes frequencies. So there you go. Hits one tower, changes frequencies on a second tower, and then it can relay to us. Telemetry allows electronic signals to be converted into coded audible signals. Signals can be transmitted by radio or telephone to a receiver with a decoder at the hospital. Data from cardiac monitors can be transmitted via Bluetooth-enabled mobile devices. EMTs often communicate with receiving facilities by cellular phone, simply low-power portable radios. Satellite phones are another option. A scanner is a radio receiving the scans across several frequencies. Conversations can be easily overheard. So scanner land, we've all heard of scanner land. That's why we have to be careful when we're on the radio on what we say. Ambulances usually have an external public address system. EMS systems may use a variety of two-way radio hardware. Simplex to push and talk, release to listen. Duplex is simultaneously talk and listen. Or multiplex utilizes two or more frequencies. EMD channels are reserved for EMS only. Trunking system assign more frequencies. An interoperable communication system allows all of the agencies involved to share valuable information in real time. Mobile data terminal inside ambulance, so it receives data directly from dispatch center. Allow for expanded communication and compatibility. So these are like the ones that have the maps and has the computer up front. You can see everything dispatch is putting in. The Federal Communication Commission, or FCC, regulates all radio operation in the United States, allocates specific radio frequencies, licensed call signs, establishes licensing standards and operating specifications, establishes limitations and transmit output, monitors radio operations. So it is the Federal Communication Commission that regulates radio traffic. Responding to the scene, the dispatcher. We've kind of talked about dispatchers. Receives and determines the relative importance of a 911 call, assigns appropriate EMS units. So they receive that call, they determine what type of help is needed, and then they send us, fire, EMS, whoever, PD out to the scene. So the dispatcher selects, dispatches, and directs the appropriate EMS response units, coordinates with other public safety services, provides emergency medical instructions to a telephone caller if they are an EMD dispatcher, emergency medical dispatcher. If they're just a regular blue collar dispatcher, they're not allowed to provide instruction. So just remember that EMD, emergency medical dispatchers, can give step by steps instruction. EMTs report any problems that took place during a run to the dispatcher. EMTs inform the dispatch upon arrival at the scene. So, like, we let dispatch know when we leave the building, when we arrive on scene, when we leave the scene, when we arrive at the hospital, and then when we leave the hospital, and then when we're back in service. We radio in that many times every call. The principal reason for radio communication is to facilitate communication between you and medical control. Medical control may be located at a receiving hospital, at other facility, or sometimes even in another city or state. Consulting with medical control serves several purposes. Notifies the hospital of an incoming patient, provides an opportunity to request advanced or orders from medical control, and advise the hospital of special situations. Giving a patient report. We've kind of talked about this a little bit. So the report commonly includes the following 10 elements: your unit identification and level of service. So this unit 41, advanced CMT, any special alert indicated by the patient's condition. Like if we have a stroke, I'm calling in code stroke. If I have a cardiac arrest, I'm CPR in progress. The receiving hospital and your estimated time of arrival. So my ETA is 15 minutes out. The patient's age and gender. I have a 68-year-old male who has a chief complaint of trouble breathing. The report commonly includes the following 10. We talked about a brief history. Patient has COPD. Yeah, just whatever history you want to make up there. Brief report of physical findings. So when I arrived, he was in tripod position. He has rails in all fields. His oxygen saturation was 87%. Then we move on to brief summary of care. So I placed him on, I gave him an ebb treatment, and now I've got him on like 6 liters of oxygen, and he's sitting at 98%. It says that the pressure in his chest is gone and he can breathe a lot better. So that went on to talk about response. Patient stated he can breathe better. Do you have any questions for me, or is there anything you'd like me to do before I arrive? And they'll say, yeah, go ahead and do this, or no, you're doing good. I'll see you in 15. So when we're giving that report, what we're doing is we're telling them everything we've done, or what we found, everything we've done, and how they reacted. Medical control is either offline or online, which we talked about. You may need to call medical control for permission to administer certain treatments, determine the transport destination of the patient, stop treatment, and or not transport the patient. In most areas, medical control is provided by a physician working at the receiving hospital. Many variations have developed across the country. Freestanding center or individual physicians. There are a number of ways to control access on an ambulance to hospital channel. The dispatch monitors and assigns appropriate clear medical control channels. centralizes medical emergency dispatch or response coordination centers. Be precise and deliver important information. Never use code unless directed to by a local protocol. So 10 codes, we don't use 10 codes unless that's what your local facility does. Repeat orders back for word for word, and then receive confirmation. Do not blindly follow an order that does not make sense to you. If you don't agree with it, say something. If it doesn't make sense, say something. They might have misheard you. That's why we do closed loop feedback. Doctor tells me go ahead and administer a second nitro. And I say, do you want me to give a second nitro? That is affirmative. Okay. Or if I report to the doctor that blood pressure is 90 over 60, you don't give nitro if blood pressure is below 100. And he says, go ahead and give second nitro. I'm going to question him. Are you telling me to give a nitro? Blood pressure is 90 over 60. Can you verify that you said give a second nitro? If it doesn't make sense or you don't like it, repeat it back. You're talking for the patient, so remember that. Information regarding special situations. You may initiate communication with hospitals to advise them of an extraordinary call or situation. Example of a special situation, hazardous material situation, rescue in progress, multiple casualty incident. These are the things we want to call ahead and go, hey, heads up, this is what's coming. So they can get everything they need ready. Keep several points in mind. The earlier the notification, the better. Provide an estimate of number of patients. Identify any special needs. Follow your system's plan. We get a mass casualty, we need to let the hospital know we're rolling in with 15 some patients. Or we get a chemical spill and someone's in it. I'm going to try to decontam before I take, but they need to know what's coming in the door. So just stay in contact with your medical control. Maintenance of radio equipment, like other EMS equipment. Radio equipment must be serviced. We check it every single day when we do our truck checks. It may fail during a run. Have a backup plan. We all have cell phones. That's the best backup plan. Okay. When healthcare providers force their culture's values into their patients because they believe their values are better, they are displaying D. So D was culture and position. When communicating with an older patient, you should approach the patient slowly and calmly, sit back and avoid making patient uncomfortable. Raise your voice to ensure the patient can hear you. Obtain a majority of your information from the family members. A, slowly, calmly. When caring for a 5-year-old boy with respiratory distress, you should avoid direct eye contact. Avoid letting the child hold any toys. Avoid alerting the child prior to patient procedures. Allow a parent or caregiver to hold the child if the situation allows. D, right? Anything that keeps the kid calm, that's what we do. Which of the following pieces of patient information is the least pertinent when giving a verbal report to a nurse or physician at the hospital? The patient's name and age, that's important. The patient's family medical history. Vital signs that may have changed, that's important. Medications that the patient is taking, that could be important. I'm going to go B. Yeah. Family medical history doesn't matter. Patient history matters. Which of the following statements about the patient care report is true? It is not legal. It cannot be used for patient billing. It helps ensure efficiency, continuity of patient care. It is intended to use only by pre-hospital care providers. I'm gonna have to go with C. A device that receives a low frequency signal and then transmits it to a relatively higher frequency is called I think it's C. Yep, the repeater. When treating a potentially hostile patient, you should try to defuse the situation by assuming an aggressive position, staring at the patient, speaking calmly, confidently, and slowly, or verbally threatening. C. All of the following are functions of emergency medical dispatchers except alerting the appropriate EMS unit. That's what they do. Screening a call and assigning it priority. Providing emergency medical instruction to the caller. Providing medical direction to the EMT in the field. So they do assign priority and the emergency medical dispatchers can give instructions to the caller. They have nothing to do with medical direction to the EMT in the field. So D. After receiving an order, for medical control over the radio, the EMT should carry out the order immediately, disregard the order if it's not understood, obtain the necessary consent from the patient, repeat the order to the physician word for word. D. When requesting medical direction for a patient who was involved in a major car accident, the EMT should avoid using radio codes to describe the situation, questioning an order that seems inappropriate, relaying vital signs unless they are abnormal, the use of medical terminology when speaking. That's a tricky one. A. When giving a report to medical control or requesting medical direction, the EMT should avoid using codes such as 1050 or signal 70. Guys, that's chapter 4. Congratulations, you made it through chapter 1 through 4, which is honestly the worst chapters. Um, Anybody in EMS will agree with that. So, Brooke will be doing chapter 5, and I will see you on chapter 6. Thanks for putting up with me.